Hey everyone, and thanks for tuning in today. I'm here with Priscilla and Dr. Tom Frieden, who is the former director of the CDC, the Centers for Disease Control, and is currently the founder and president and CEO of a group called Resolve to Save Lives. It's a public health, global health organization that we work with through the Chan Zuckerberg Initiative as well. While a number of people are joining us on the live stream, I thought it might make sense just to start before we get into the main program. Tom, I know you're a New Yorker. In addition to running the CDC for a long time, you also worked with Mike Bloomberg when he was mayor and ran a lot of the health department there. I know New York is unfortunately one of the hot spots right now for this, and it's a really tough period. Can you tell us a little bit about what it's like in New York right now and what is giving you hope for the future here?
I was born in New York City. I did my medical training and residency here. I was at the health department for about 20 years as commissioner, ultimately, and it's really heartbreaking. Although the streets are empty of traffic, we hear sirens day and night. And their number of recorded deaths is approaching 7,000, with 400 or so or more per day. On an average day in New York City, before coronavirus, there would be about 150 deaths. So there are twice as many deaths just from coronavirus each day as there are on a normal day. So it's heartbreaking, really. And to know that healthcare workers remain really at risk. I have several of my friends have been infected giving care to patients with coronavirus. And I think back to the days after 9/11. I became health commissioner here in the aftermath of 9/11, and the rubble was still burning. But New York City did build back stronger, and I'm confident that we're a resilient city, and the losses are tragic and can't be changed. But in some ways, not only in the city, but in the world, we'll have a better understanding that we really are all connected, and all of our fate depends on what other people do. We're all in this together against a dangerous microbe.
Yeah. So Tom, we first met when you were running the CDC, and we're basically facing down the Ebola crisis at the time, and it was largely in West Africa, and it was there were a couple of cases that were starting to crop up in the United States, and a lot of your response as part of the CDC then was to make sure that we could help the countries in West Africa stand up the health response that they needed, and that was largely a very successful response. So I'm curious, from your perspective, having done that, what worked well there, and what are the basic lessons from that that may still be applicable today as we're fighting COVID?
Mark, I remember you called early and you said, what can we do to help? And you made a very generous contribution to the CDC through the CDC Foundation. We were able to use that money very quickly to respond. And I think the first lesson from Ebola that is so relevant here is the need to move fast, really fast. In parts of the world, this virus is doubling every 2 days. That means you really have hours to react. In Ebola, what we found in West Africa was if we could get in within a day or two, we could prevent a chain of transmission from going on for months. But if we were a week or two later, it was hundreds or thousands of cases and months of challenge to stop it. So you want to try to find that chain of transmission when it first starts and stop it through actually contact tracing, which is a tried and true public health method. The other two main lessons, I think, from Ebola were the importance of understanding and working with communities. When there were interventions that communities didn't understand, didn't agree with, and were threatened with, it didn't work. And related to that was the importance of working with culture. For example, in West Africa, there were dangerous traditional burial practices, and we had to work with communities to help understand and figure out how you could safely bury someone who had died without risking all of their relatives becoming sick. That's obviously very different with coronavirus, but still, whether it's using video conferencing more or figuring out ways that people can have new ways of connecting without being physically together in this era of physical distancing, there are some lessons to be learned, but every epidemic is different and every community has its own strengths that can be used to help fight that epidemic.
Yeah, so I think we should spend most of the time today talking about your thoughts on how we can safely reopen society. I mean, that's obviously, having run the CDC, I mean, that's a thing that you have a huge amount of perspective on. And you wrote a great op-ed in the New York Times about that I would encourage everyone who's watching this to go check out. But before we go to that, maybe just a few questions on kind of what we're currently seeing and what you expect for the next few months.
Yeah, so I mean, one that's on a lot of people's minds is like, what will life after this look like? You know, we've all been home and doing our part and staying home so that we can keep ourselves and the people around us healthy. But when do you think it will be safe for us to go back to life outside of our homes?
And obviously it's impossible to predict exactly, and it'll depend on what the response is and all that. But if you had to kind of give an estimate today of when you think stuff will start opening back up again, before we get into how to do that safely, how are you thinking about that?
I think really the key question isn't about the date, it's about the data. And if we think of what we're doing now, is we have beat a strategic retreat. We're hunkered down, sheltering in place, waiting for this wave of infections to quiet down. But when we come back out again, the virus will still be out there, it'll still be spreading. So we're going to have to do it in a way that's very, very careful. And the way I think of it is we have to look at three things. One of them is, how much is the virus spreading? Because if it's spreading widely, we can't come out safely. Second is, how prepared is our healthcare system? Are we able to protect healthcare workers so they don't get infected and treat patients well so they can survive whenever possible to the greatest survival rate possible? And perhaps most critically, how ready are we to find and stop the spread of the cases and clusters that will inevitably arise? That's why I've focused on this concept of test, isolate, trace, and quarantine, these four corners of a box, because if we do those four things well, we can come out as soon and as safely as possible. But I think to Priscilla's first question, it's not just about when, it's about how. And some things are going to be different until we have a vaccine, which could be 1 or 2 years or even longer. And that includes, I think, not shaking hands. That includes much better hand washing, probably mandatory hand sanitizers at the entrance of all buildings, getting to where we will have touch-free elevator buttons and doors and doorknobs. These are changes that we're going to need to make because, unfortunately, COVID spreads like a super SARS. It spreads all of the way SARS spread and more.
And so there's been a lot of questions about whether or not there's going to be new waves, and you already referenced that there might be future waves. Tell us a little bit about how that may or may not happen.
One thing that looks highly likely is that most people haven't been exposed to it. Even in a place as terribly hard hit as New York City, the great majority of people don't have the infection and there's no immunity. So if people go out again and the virus begins spreading, we'll see the same kind of spread. Now, there are a lot of unknowns. We don't know if it will behave differently in different weather. We don't know if the virus will mutate to be more or less infectious or more or less deadly. But from everything we've seen so far, whenever the virus is reintroduced or people resume social activity, there is spread. And that's why it's so important that we shield those who are most vulnerable. That's the elderly and people with underlying health conditions.
Yeah. Well, so you've, in the different roles that you've had, you focused a lot on global public health, right? Not just in the United States. And there are a lot of places around the world where there haven't been massive reported outbreaks yet, including in India and a lot of countries in Africa. What's your outlook on how those countries and places are prepared, and what we should expect in the months ahead in countries that haven't had large reported outbreaks yet?
Only time will tell what will happen. For Asia and Africa, the age structure of the population is an advantage because we know that younger people do much better than older people. So without a large elder population, you may not see nearly as high a rate of serious illness and death in these communities. But on the other hand, the healthcare system is much less ready to address this, and the social impacts are enormous. What we're seeing in the work that we're doing in Africa in particular is the balance between physical distancing to reduce spread of the virus and the risk of social, economic, and security problems in society is a very delicate balance. And if the choice, as we've been working with other organizations to do surveys throughout Africa to ask people and learn from the community, and some of the answers are, yes, I can stay home, but I'm going to starve. And we have to deal with that reality to support communities, engage communities, and figure out how to balance minimizing the public health impact and also minimizing the social and economic and even security risks.
Okay, so I want to make sure that we spend most of the time today talking about not just the acute response up front, but how do we safely reopen society too. So you wrote this op-ed. I think it would be worth just going through for a few minutes. What are the key high-level points that you think we need to make sure that we get right, that are parts of this plan for reopening society?
We're calling it box it in, box in COVID, or box COVID in. Test widely. The four corners of that box are testing, isolation, contact tracing, and quarantine of contacts. And just to take them each for a moment, testing has to be widespread. It has to be able to be available for really anyone with pneumonia, any healthcare worker who has cough or fever and might be sick. Anytime there's a cluster of cases, a group of cases, whether it's in a nursing home or a homeless shelter, or patients who are identified through tracking of a number of patients in one zip code or one city or one hospital, all of that and more needs to be available so that tests can be done. And what we see is really massive testing approaches in South Korea and elsewhere where they're drive-through, and that's scaling up in the US, but it's not anywhere near the level it needs to be here. And unless that's there, it's going to be very difficult to open safely. Think of a box. If you have any corner of it weak, the virus can escape. Isolation is also important. And that means our hospitals, that means nursing homes, that means also if you're mildly ill and you decide to stay home, that's probably fine. But how do we make sure that you don't spread it to anyone when you're there? And what if you live with someone who's medically vulnerable or an elderly parent or grandparent? What countries around the world have done is offer, or some of them have forced, I don't think that's appropriate for the US.
I found a graphic. I'm going to hold this up for people so that they can see it.
Yeah,
Great,
keep going.
Around the world, in that second one, the isolate, get people out of their home if need be, voluntarily, I would say, in the US. The third is contact tracing, and that's something that's not widely understood, but it's a tried and true public health method. It's about talking with someone who's sick, gaining their trust, supporting them for the services that they need, and then helping them to identify the people who need to be warned that they may have been exposed to them. And then finally finding those contacts and quarantining them for the whole period that they might become ill, so that if they do become ill, they're not going to spread it to others. And if we do those four things right, we can keep the virus in a box to get out of the box that we're in now. We can get ahead of the virus instead of responding to it.
Yeah, so you mentioned that data is going to be incredibly important here. And nowadays, oftentimes when people think about data, they may think about technology. But you've said that this is not necessarily about technology, and you've emphasized here the importance of manual contact tracing. What do we need to do to get that really high quality contact tracing that's necessary to execute on this strategy?
It's going to require a huge number of people. If we learn from countries around the world, look at China that's been dealing with it for the longest. They've done contact tracing of more than 700,000 people for 14 days. In the city of Wuhan, the hardest hit city, they had 1,800 teams of 5 people, each led by a public health epidemiologist. That's 9,000 people. So lots of people, well supported, but it's not just about the contact tracing, it's about sensitive interviewing with people. I did most of my career before in tuberculosis control, and we do contact tracing and tuberculosis control as well. I think back to a time when we had a high school choir, and there was a young woman, a student at that choir, a 10th grader, and she had tuberculosis. She didn't know it, but singing is a really good way to spread infection, unfortunately. And so many people around her became infected and several became ill. We had to go out to each of their homes. We had to explain to them that they've been exposed. We never gave the name of the student who had exposed them. And that's tried and true public health. And a lot of society can support public health and support patients in context. For example, suppose a patient needs to come out of their home and stay in a hotel or motel or dormitory. What services does that person need? Food, laundry, social, emotional support, entertainment, high-speed internet. One country gave people unlimited Netflix movies so they would stay and be comfortable where they are. It's really about making the patient the VIP of the program. That's the secret of public health, and gaining, and retaining the trust of the community.
So in our conversations, one of the concerns that you've raised is that there's a tendency sometimes for society overall to focus on the shiny new thing. In this case, it might be how we can use apps or technology to fulfill some of these roles that are unproven, whether that can help, where the traditional approaches have been proven to work. And it's on the one hand, if people want to try new things, that's great, and that can be helpful, as long as we don't take away the attention and investment from the things that we know are necessary to work. And you've talked about how we will potentially need somewhere between 100,000 to maybe 300,000 people in the country working on contact tracing in order to do this well. Maybe talk a bit about that. What you see is how is it possible to stand up that kind of effort? And you talked a little bit about why it's important to have people do that rather than some of the kind of newer approaches that people are talking about. But maybe just kind of draw a sharper contrast if I'm summarizing your point correctly about what you'd expect those people to be able to do that you'd worry that technology alone wouldn't be able to.
A good public health program uses data to guide its action, and a great public health program uses real-time data to guide action. So there are some really important uses of new technology. For example, understanding to what extent people are physically distancing in different communities. That's an aggregate data feed that can be used by government, by public health, by societal leaders to say, hey, we're doing a good job, or we need to back off from some of the social interactions that we're having, physical interactions that we're having, so that we can tamp down the virus. That's a great use of it. Symptom screening is something that's being looked at now and may be able to give a hint to where the virus is emerging before we're able even to test, even if we had a perfect testing capacity. So I think there's some really good potential uses. There's a lot of interest in, can we have our phones identify who we've been in contact with or who's been in contact with us who might have been infectious. That's an interesting technology. It's an interesting idea. Absolutely, it's important to look at it, and maybe that'll be really helpful. But I think it's scary to people, and it's something that would have to be done with full transparency and consent. And it's not what traditional contact tracing is. Traditional contact tracing is about gaining someone's trust, meeting their needs, helping them to warn the people who've been around them who may have been exposed. It's hard work, but it does work. And it takes people who are trained, supervised, and supported. And I think there probably are some ways that technology can help. If it's hard to reach someone and you're able to send them a message by social media, that's a new way of reaching people that we didn't have 10, 20 years ago when contact tracing was done more commonly for things. I will mention one thing that's been quite interesting to us as we're working both in Africa and in the US. This concept is much better understood in Africa than it is here. Liberia is scaling up to 6,000 contact tracers. And when they had the first 3 cases, they had hundreds of contacts identified, quarantined, and tracked to make sure that if they got sick, they would not make other people sick. So some of the things that we have to do are the basics, but we can make them work better by doing them smarter, by getting resources for the patients, for the contacts, and also for the people doing the contact tracing.
So it sounds like technology can help us figure out what the connections look like, but you still need a person for the bedside manner or the human touch to actually help people navigate life once they've figured out that they need to either quarantine or if they're sick, so that they continue to take care of themselves and prevent exposure to those around them.
I think that's right. It really does take human interaction to be able to gain someone's trust and determine what's best to help them stay safe and keep their family, friends, and those around them safe. And ultimately, there's no replacement for that person-to-person bond.
Got it.
So you talk about how in Liberia and potentially in other places in West Africa, there's more familiarity with the idea of needing a big public health response on contact tracing. Certainly, I think we've also seen in Asia, where countries have had more exposure to SARS, there was more mask wearing and things like that in advance. What do you think it's going to take in the United States in order to build up the amount of resource or the human manual effort that's required to do the scale of the contact tracing that's necessary? If this really is 100,000 or more people, what does that look like? And I mean, I know that this is something that Facebook is looking at how we can use our tools to help recruit people. It's a big part of what we do, or help people disseminate messages or communicate with people. That's certainly core to what we do. But what do you think, whether it's a company like Facebook or other nonprofits or other folks, what can folks be doing to help stand up this big effort?
There are a lot of aspects to it. So one is for people who are in isolation or quarantine, whether in their own homes or in a hotel or motel or dorm, how about wraparound services for them so that it's their incentive to stay there, they're supported to stay there, that's in their interest, but it's also in all of our interests so that they don't spread the virus. In terms of the contact tracers themselves, we really are going to need a federal, state, city, local effort at all levels. We need guidance, tools, resources from the federal level. We need, at the local level, local leadership and identify the best people. Not everyone has the skill set to do this. There's an old saying that someone who does contact investigations for sexually transmitted diseases, which is a core public health function, can elicit the names of contacts from a rock. You really do have to gain someone's trust and help them understand that this is a responsibility to warn others that they may have been exposed and that you're there to help. And if they become more sick, they'll be at the front of the line for whatever services they need. And their contacts, if they're warned, can prevent the spread of the disease. And that's something that I think community leaders can help people understand. If someone calls up or knocks on your door and says, you've been exposed to coronavirus, I mean, that's really shocking, I think, for most people, but maybe we put it in the framework of a hurricane warning. You'd want government to warn you if a hurricane was coming so that you could protect yourself and your family. In the same way, you have really a right to be warned that you've been exposed to this virus and might become very ill, or even if you don't become ill, you might spread it to a family member.
So there's a question from Devin on the thread. We're saying it's a tough call, safety versus privacy and balancing some of these programs. How do you think about that in the manual approach to contact tracing and some of the technical approaches that are being proposed?
There's an old saying that your right to swing your fist ends at my nose. So you have a right to do what you want to do, but you don't have a right to spread disease that infects me. And I think that's a core public health principle. And therefore, someone who is infectious with this virus needs to ensure that they don't spread it to others to the greatest potential possible. Because even if they're not very sick from it, someone else could die from it. And that's the ethical principle that underlies this, that we're trying to protect as many people as possible, prevent as much suffering, illness, and death as possible. And yes, that may require asking you, hey, think back to those 2 days before you were sick until today when you're isolated. Now, during all of that time, who are the people who you were physically close to who might have gotten exposed? And I'm going to contact them one by one, or work with you to contact them one by one to warn them so that they can quarantine and we can stop this chain of transmission. Otherwise, it can explode. It's very hard for people to get their mind around exponential growth. But what we have the risk of here is exponential growth. And if we don't do the quick testing, isolation, contact tracing, and quarantine, that exponential growth will continue, or when we get back into society, resume.
So on the question of resuming life, there's a lot of questions from Joe, Jennifer. Everyone has something that they need to get back to, whether it's their job that's currently non-essential, getting their kids to school, seeing their elderly parents. Like I've seen people write about sort of a phase back response. And how should we think about like when these different parts of life will phase back in?
I do think it's a question of gradually loosening the faucet rather than letting the floodgates open on activity. And that way we can track, and if things begin getting out of hand, we can tighten again. Older people, people who are medically vulnerable, they're going to need to shelter in place for longer. Younger people may be able to, in a phased way, when all of the other conditions are met, come out more readily or more, but to a different new normal where we're risking contact less. And in different communities, different activities will be particularly important or strategic. One issue is daycare. A lot of parents have difficulty working, whether at home or outside, because of the lack of daycare. And young kids don't often get severely ill from this. So you might want to open your daycares in a phased way, but ensure that no kids who are medically vulnerable go there, and no staff who are medically vulnerable are staffing the daycares. So there are ways to do this that we can gradually reopen, and it should be different in different parts of the country at different times, but every part of the country needs to be able to track to see whether they've got virus spread, how strong their healthcare system is, and whether they have the public health capacity to box it in and keep the virus in a box.
So when you talk about tracking the spread of it, how much of that comes down to broad-based testing of the population and basically having the ability to test more broadly, versus how much of this is just aggregate data on a population level, like the symptom surveys that we've started rolling out on Facebook, where broadly we can ask people if they're feeling symptoms, fever, shortness of breath, loss of smell, different things that are associated with COVID, and then can basically produce a county by county map on a day-to-day basis of where there are surges in people feeling symptoms. What types of tools do you think are necessary in order to have a clear enough picture of what's going on to make the kind of public health decisions that need to get made on these policies for opening and closing the faucet?
We're going to have to continuously and iteratively get better at tracking the virus, figuring out the different data streams that'll make a difference. The most gruesome one is deaths, and deaths from COVID are a late indicator, but are an important one to track. And globally, we still don't count deaths. There's still large parts of the world where real time or even anytime a collection of data on who's dying, how many people, where, and from what is not available. So that's very important. There was an epidemiologist who said the death rate is a fact, everything else is an inference. And there are lots of other things we can look at. Testing, test results, what proportion of people test positive, what proportion of people with cough and fever test positive. We can learn from influenza, where we have very good surveillance systems. There's a great system called the syndromic surveillance system that looks at the chief complaint, what people complain of or say they're sick with when they go into emergency departments. And when you analyze that, and maybe we should add can't smell or can't taste to that, you can get an early warning of what's happening with this and an early indication that it's getting better. The kind of symptom surveys that you're mentioning have a lot of promise, and we're looking forward to seeing if they work out and correlate. We'll have to tune these things and figure out how they work best to track the virus activity.
Yeah, since we've been working together, we've spent some time talking about pandemics and pandemic preparedness. You also mentioned in your op-ed and just now, how do we need to be able to detect diseases early on in order to prevent diseases spreading like this going forward, or even to lesser degrees? This is something that we're really interested in supporting and investing in at the Chan Zuckerberg Initiative. What do you think that should look like in an ideal world, the early detection system?
Really, it's like a smoke alarm and a sprinkler system in a building. All over the world, there are countries that have huge gaps in their ability to find, stop, and prevent health threats from spreading. And what we've seen is over the last few years, with your support and support of others, the World Health Organization and others have built now a clear sense of where we're best prepared and where we have gaps. And our organization, Resolve to Save Lives, has a Prevent Epidemics initiative, preventepidemics.org. And on that website, we put transparently where the gaps are. And we've now seen over 112 countries go through a rigorous, externally validated evaluation of how ready they are. And those report cards have identified close to 10,000 life-threatening gaps all around the world. And if that alarm system and sprinkler system isn't working anywhere, all of us are less safe. So one thing I'm optimistic about is coming out of this terrible pandemic, there will be a global recognition that we need to take that map that looks red and yellow in most of the world now and turn it green for preparedness. And that means laboratory networks, trained epidemiologists, rapid response teams, effective communication, community engagement, identifying hotspots around the world where if a disease did emerge, we wouldn't be able to control it, and then really cohesively coming together as a world to recognize we're all in this together. We're all in this to fight a virus. That's the enemy. And this is just one virus. Each year, on average, we identify globally one new microbe, and the next one is inevitable. What's not inevitable is that we'll still be so underprepared as a world.
Interesting. So, I mean, how frequently, how often does one of those new microbes that emerges end up being an outbreak? Obviously, this is a generational thing that we're going through now, but what's the frequency of things that have the potential to spread and be broader outbreaks if they're not managed well?
About every year, one or another microbe comes out, and what we're seeing is more animal-human interface as the human population increases and we encroach on animal habitats, and that's the usual way that viruses enter the human population. This is a pandemic like none for 100 years. This is the worst pandemic since the great influenza pandemic of 1918, 1919. So this is an extraordinary event, and it is something that requires an all-hands-on-deck response so that we can focus on learning as much as possible, so we can do as much as possible to limit the number of deaths and the amount of societal dislocation it causes.
In such a momentous and sort of once in a lifetime thing, hopefully, what gives you hope?
I think there is a better recognition that we are all in this together, that what any of us do can affect what all of us are going to experience. And therefore, it's in all of our best interest to have solidarity, to learn with each other, to help countries all around the world stop those gaps, to fill the gaps, to stop the spread. Because even if any one country controls this disease or the next one, they'll then be vulnerable to it being imported and coming in from elsewhere. That's why it's so important that we not only find the gaps, but fill the gaps anywhere they exist.
Yeah.
All right. Is there, I mean, I think we've gone through a lot of ground so far. Are there any topics that you think we should drill into a bit deeper, or things that we didn't cover in the way that you'd want to?
Well, there's so much about this virus that we're learning literally every day. I wouldn't want to lose the importance of protecting our healthcare workers. We're seeing just today a report coming out of the CDC that even though much of the information was missing, 10,000 healthcare workers had been infected in the United States. 10,000 healthcare workers. That's just horrific. We have to protect the front lines. And it's not just about the protective equipment, which is crucially important, but also making sure that healthcare is structured to be safer. And another silver lining from this could be that we have fewer healthcare associated infections, which are already a leading cause of death in the US, killing as many as 100,000 Americans each year. Having much safer healthcare is important for our patients, for our healthcare workers, and really, I wouldn't want communities opening up again if it results in so many healthcare workers getting infected and tragically dying. So supporting our front lines is crucially important. And that might mean in a place like New York City today that we're telling people with mild symptoms, don't go in for care. There's just not the capacity to safely care for and treat you. Isolate, and we'll make sure that it tries to stop with you. We try to make sure the virus stops with you. But the healthcare workers are the heroes of this battle, and we need to do everything possible to support them.
Yeah, so
Couldn't agree more.
Yeah, that's well said. Maybe before we wrap, it would be useful just to talk for a little bit about what your organization, Resolve to Save Lives, is doing to help out here. And we've talked a lot about what the broad national and international response should be. But when you were getting started with Resolve, we talked very early on, and we basically talked about how you had a plan where through some basic public health interventions, you felt that over a 5 to 10 year period, potentially tens of millions of people's lives could be saved. And now, of course, given this pandemic, it makes sense to pivot the focus of what you're doing to making sure that we're prepared and getting the response as good as possible. But maybe just take for a couple of minutes and talk about what your organization is doing here.
Thanks, Mark. And you and I and Priscilla discussed this as we were creating it. We really wanted to identify the areas that we saw as at the edge, where we could make a huge difference if we had a catalytic investment with which you and the Bill and Melinda Gates Foundation, Mike Bloomberg's foundation, has supported. And we've worked in two different areas. One of them is preventing epidemics, what we've been talking about so far, finding those gaps and filling them, getting countries the capacity so that they can be safer and the world can be safer from epidemics. Our other major activity is preventing cardiovascular deaths. And we think that globally, there's the possibility of preventing 100 million deaths from heart attack and stroke over the next 30 years by focusing on simple interventions like effective treatment of high blood pressure, the global elimination of artificial trans fat, and reducing the amount of sodium we consume. These are core public health interventions. We know what to do, but we're not yet doing it. And bridging that gap between what we know and what we do globally will literally save tens of millions of lives and can help prevent the next pandemic and tamp down this one.
Yeah. All right. Well, Tom, thank you for everything that you are doing, and thank you for joining us. I think this has been a useful session for a lot of people to hear from you on what to expect and what hopefully the plan looks like for society going forward. So thank you again. All right. Now we'll see you soon.
Thank you, Tom.
Thank you. Thanks to both of you.
Take care.
You too. Stay safe.